Hi, my name is Shamaila Iqbal. I'm the Director for Neurosurgery Division and the System Lead Spine Navigator. What does that mean? Which means I oversee the strategic and clinical operations across our neurosurgical and spine program. I also help patients navigate their care journey from diagnosis through recovery, ensuring that they receive coordinated and evidence-based compassionate care. Now I'm going to introduce Dr. Lamb, who is Dr. Edward Lamb, who is a board certified physician in physical medicine and rehabilitation who joined Inova in 2025. With a decade of experience,
Jamila, I think you accidentally muted yourself.
okay, can you hear me?
Yes, we can hear you now.
Okay, good. Sorry about that.
No worries.
With a decade of experience, Dr. Lamb is your go-to expert for treating painful spinal conditions like back, leg, neck, or arm pain caused by spinal stenosis, disc herniation, and facet arthritis. Dr. Lamb offers a variety of services from diagnostic consultation and conservative treatment to non-opioid medication management. When needed, he performs minimally invasive procedures like spinal cord stimulation. He performs minimally invasive procedures, spinal cord stimulations, nerve root blocks, epidural steroid injections, and joint radiofrequency ablation. He also helps diagnose complex spinal conditions to assist with surgical planning. Passionate about improving patients' quality of care, Dr. Lamb uses evidence-based medicine to create personalized treatment plans. He takes the time to educate his patients about the condition and guides them through their treatment options. He's originally from New York, now lives in Northern Virginia with his wife and 2 children, a tabby cat and a German Shepherd. Please welcome Dr. Lamb, Edward.
Thank you for the introduction. Hello, everyone. Thanks for taking your time this evening to listen to a talk about back pain. So I'm going to try to make this interesting as possible. And I understand there's a wide audience, anywhere from, our regular patients, regular people that just want some relief or want to know what to do to prevent having debilitating back pain, anywhere to providers and doctors that kind of see this on a day-to-day basis. First of all, can you guys see my mouse moving around on the screen, by the way?
I can.
Great. Okay. So we're going to get started here. So I recently joined Inova. I used to practice in Winchester. My primary campus is at Fair Oaks, and I'm really excited to bring you guys this presentation today. A little bit about my training. So I've gotten a few questions about physicians. Hey, what is interventional spine? Are you guys just like pain, but only for spine, and you don't give opioids? What? Only the spine stuff? In essence, you can think of it like that, but I want to say that um, we are kind of a little bit more specialized. So most people that undergo an interventional spine care fellowship, well, I say all people, actually go through a different pathway. We're actually trained under physical medicine and rehab. So we would take care of patients in the hospital after a spinal cord injury, a stroke, things like that. Our background on musculoskeletal medicine and really plays a role in how we approach a patient and tackle the problem. So we kind of think of ourselves like investigators, but with a certain procedural skill set, if you will. Versus your ACGME pain medicine fellowships, they do a lot more than us. They're trained in ultrasound guided blocks for, let's say you have abdominal pain after a certain surgery. These kind of internal things, they can tackle those issues very, very well. And that's kind of the surface difference between us. So we use, as the name implies, interventional spine, we use image-guided procedures to help us accomplish our goals, which is finding the source of where the patient's pain is coming from, and then moving on with the standard of care, a procedure to see if they improve and respond, and if not, whether they need a referral to surgery for more permanent or successful outcomes. So we generally read all of our own MRIs. In the past, I think reading MRIs was really more of a thing for neurosurgeons. They were kind of the expert on reading MRIs. Radiology, they're the experts on reading MRIs. But more and more in the last 5 to 10 years, you find the newer physicians really have a lot of training in personally reading MRIs because the anatomy of what we're treating dictates it. So we generally try to get a good story and we try to see where the patient's pain is coming from and zone in on that. So something important to keep in mind is when you see a spine doctor, they're not just using the imaging to help treat you. The MRI, as great as it is only one piece of the puzzle. The patient's examination and most importantly, story plays a huge role. What happens when we see an 80-year-old patient with all sorts of degenerative disease, disc, joints, pinched nerves? We have to find what fits with the patient's diagnosis. So some of the objectives today, a broad outline. I want to discuss some of the spine biomechanics and how to prevent some easily preventable injuries. I want to talk about how we approach it diagnostically, how we start thinking about where a patient's pain might be coming from, some examples of how we treat it, and then I'm really excited to talk about Intercept, the newer studies and treatments that we have on the horizon. Mainly, it was previously done at major academic centers, San Francisco, UVA. Now, a lot of private practices are doing it as well. And then now, non-for-profit organizations like Inova we're working on it. So I'm actually one of the physicians that's trying to bring this tech into Inova, working with other neurosurgeons and orthopedic surgeons. Something that some providers might have seen, I'm just going to put this in there before we get started. So the elephant in the room is some of you might have read this very recent study from neurology, just from February 2025, from the British Medical Journal, saying what we do as a field is not helpful to patients, to anyone for chronic pain. And the study was under a lot of scrutiny and for good reasons. A lot of it just really did not make sense. And I hope that after this talk, after I explain how we approach problems, the different kind of procedures and the nuances between them, that you would understand why that study was so fundamentally flawed. All right. So there's this concept of a pain generator, right? So everything in the body, if you feel pain, it's because some nerve or some structure is sending a signal to your brain, allowing you to feel it. So there are a lot of different structures in the spine that are innervated by nerves that can cause pain. Part of the difficulty in the spine world is there's a lot of things crammed in a very small area. So when we look at the picture on the left there, this entire region here is about the size of maybe 2 Coke cans, right? So unlike major joints like the knees and hips, a lot of different things can cause back pain. A lot of different things can cause pain to the hips and also the leg. When we're looking at the spine itself, some of the things that can cause back pain itself, the vertebra, right? The bones, we've all heard of somebody with maybe a vertebral compression fracture. Maybe they have some osteoporosis and they bend the wrong way and now they have a crush fracture and they're in the hospital, maybe talking to a surgeon, getting a bone kyphoplasty, getting bone cement. You have your discs, which is the classic cause of back pain. Typically tends to be in younger folks, age 55 and younger. It can be acute, meaning within 6 months or so, within a year, or chronic, more than a year. You have your spinal ligaments in the back, and you have your facet joints, right? Your arthritic joints. Something to keep in mind is that it's highly unlikely to have just one issue be the end all be all. The spine is one organ, and when your spine degenerates for patients with chronic pain, one thing leads to another. And when we talk about the mechanics, it'll make a lot more sense. So the bullet points on the right here, you see we have discs, annular tears, meaning little microscopic tears along the outside of the disc. You can think of the disc like a jelly-filled donut. The jelly being on the inside, the dough of the donut surrounding it. Annular tears are essentially little microscopic tears along the dough of the donut, which can cause inflammation. You have your facet joints, you have your what I call spine mimickers. They feel like spinal pain, causing pain in the back, maybe in the hip, but they're actually not. So we think of those like your intra-articular knee pain, so the ball and socket joint in the groin. You can also have degenerative spinal processes. Your muscle can cause pain. Myofascial pain is not talked about enough. I think, for the vast majority of people with acute pain, they might have, you know, injured a muscle, have some myofascial pain, and then they feel better very quickly with some rest or some lidocaine patches. That's the vast majority of patients. The patients that end up seeing me, they have more chronic issues or more long-standing issues within several weeks, maybe less likely because muscle pain should have gotten better. And there's something else that I'm really excited to talk about the Intercept procedure is the vertebrae. End plates can also cause pain. So I want to talk about this column model. When we think of what can cause pain in the back, I want to think about the anterior column and the posterior column. Anterior meaning in front, so the side toward your abs. The posterior column meaning posterior in the back towards the small lower back. And I've separated in a red line the anterior column disease. You want to think about discs being cause of pain, vertebra, compression fracture, the end plates. Why do we separate anterior and posterior as a model? Because of the presentation. So when patients come in and they tell us they have pain, one of the first things we ask is, better with what maneuvers? What makes it better? What makes it worse, right? Seems like a very simple question, but there's actually a lot of that. It actually tells us a lot of information and a lot. So your anterior column, disc, compression fractures, vertebrae, end plates, those are activities where it gets worse as you're bending forward. And it makes a lot of sense. When you bend forward, all these vertebrae bend forward, and more of the stress is along the front of the disc, pressurizing the disc, pressurizing the vertebra, putting more stress on the anterior or front of the spine. Similarly, when you bend backward, let's say you're a cheerleader and you're bending backwards, right? The posterior columns might pose an issue because the facet joints, the small little knuckles, as I call them, that connect your vertebra, they will have more force on each other and they can hurt, along with your spinal ligaments and things like that. This middle column here, it's part of a different model, and I'm just putting the picture in there, but typically in the middle, you're thinking about maybe a disc herniation, pinching a nerve, or causing spinal stenosis. In terms of spine mechanics, it's really important to remember that when you're standing upright, the pressure inside the disc is a certain amount. And when you bend forward, such as when you're picking up an object, or even when you're sitting down the disc is more pressurized. When we look at the picture that I'm circling here, when your discs start to degenerate, and what do we mean by degenerate, right? People say that all the time. What does it mean? It means the discs are flatter. That's a very easy way to see it. But early signs of disc degeneration, the disc may look darker. So when you're looking at the disc under MRI, darker because the disc itself is attracting less fluid. The cellular matrix inside the disc, the jelly of the donut, it's a jelly because it's holding on. These little proteoglycans, these little strands of protein are holding on to water molecules. And as we age, those little matrices, those little proteins break off, and it's a less effective sponge. It's less able. And when you're not able to hold water, that jelly is flatter. The whole point of your disc is acting as a shock absorber. Well, you're going to have less shock absorption. And let's say you pop your tires in your car. Well, what gets more force? Now the suspension gets more force and they may start to go. You don't fix that pop tire. Want to think about it mechanically exactly the same way. When the discs start to get darker, they degenerate. Now, all of a sudden, you're getting a lot more force along the posterior column along the joints. And then when you bend forward, the disc themselves starts to get more force. So the whole kinetic chain, the whole machine works less efficiently. Something else to think about, you know, degenerative process are one thing, but what about those of us who are really active? Here in Northern Virginia, we take care of a lot of people that take pride in staying fit, going to the gym, being active. Well, even those patients, if you have bad mechanics, for example, on the right here, when you have a high sacral angle, that may lead to poor posture and increased degeneration in the lumbar facet joints. So the key point is when you're sitting, you're actually pressurizing your disc twofold compared to when you're standing. So sitting is the new smoking, as I say. Here's a very good picture of what I just discussed. The picture that I'm out circling here, when the discs start to become flatter, more percentage of the spinal load goes to the joints. Now, you might be thinking, okay, well, Dr. Lamb, we get older, the discs degenerate, it leads to more arthritis in the facet joints. Very common thing. Yes, that's correct. However, when you look at the picture on the right, when you're just arthritis isn't so much an issue because treatments for it, as we'll discuss, is actually very successful, 95% efficacy rate. The issue becomes more when the joints grow and grow. And we all have a grandma, a grandpa with these big knuckles on their hands. The same exact process occurs in the spine. As the knuckle grows, it starts to push into that canal where the nerve is. So picture on the left that I'm circling here, picture on the right, you see that nerve being smaller. So what am I trying to say with all this? Have good posture. But honestly, the vast majority of us sit all day at work. How do we help ourselves, right? Sitting is the new smoking. I think a lot of people here have heard of kneeling chairs. Now, I'm going to put in my plug. I own no stock in these companies. There's no reason I'm trying to sell you anything. I have 2 of these chairs at home, and I highly recommend them. So the picture on the left is probably how most of us sit when we start to get tired at the day. Looking head forward, got that turtleneck going on, bending forward, poor posture in the spine. We strive to sit like the gentleman in the middle, where we're looking straight ahead with a nice straight back, legs flat on the floor. But the problem is, even then, when you're sitting, the discs are pressurized twofold. You're leading to unnecessary pressure in the disc. They will age faster. People that sit a lot will have earlier disc degeneration. This cartoon on the bottom demonstrates that. When you're standing, look at this curvature that I'm out. The spine has this normal lordosis, we call this normal curvature, and that's how our body wants to be. That's how you're improving spinal shock absorption, right? The disc acts as a shock absorber, but also the way that the spine is aligned, that motion can act as a shock absorber. When you're sitting down flat, this that I'm outlining is the femur, your thigh bone. When you're sitting at a 90 degrees angle, even when your back is straight, you see your spine is very straight here. You're losing that lumbar lordosis, you're losing that curvature. So the disc will age faster. And as we discussed, faster aging discs, faster aging facet joints, and eventually you develop spinal stenosis where you pinch your nerve, right? The kneeling chair, how does that help? When you're sitting in this special chair, look at his thigh. His thigh is dropped about 60 degrees, so it's not at a 90 degrees angle from his back. Now, that's really important because when you're at 60 degrees, that's pretty much the optimal angle or to resume as much normal lumbar curvature as you can without standing. A lot of us may not be able to bring one of these chairs to the office, so myself included, I guess I just haven't gotten it. So what I do is I sit on a stool. I raise the stool up and then I sit on the very edge of the stool. I drop my knee and I kind of tuck my ankles right underneath my buttocks and I imitate that sitting posture. And when I spend long days in the office writing notes, that's what I do. Giving you a talk right now, that's what I'm doing. So probably for our younger folks in the crowd, this is probably the most important thing that you should take away from this entire long presentation. Disc herniations. So disc herniations tends to happen in younger folks because they still have a lot of disc volume to herniate. Now, do not bend and twist at the same time. The reason for that is the vast majority of disc herniations don't go straight in the middle or your spinal canal. It actually goes off to the side. Why is that? Well, along the back of your disc, so to highlight, this is the back here, and then your abs are this way. Along right here is something called the posterior longitudinal ligament. The ligament, unfortunately, was not designed in a straightforward fashion. It does not go straight down. When you bend forward, this piece that I'm highlighting with my mouse, it's blocking the way, so you just can't really go backwards all too much until you get older and there's some laxity in the ligament. It becomes more stretchy. But why don't we want to bend and twist at the same time? Well, when you bend forward, the disc wants to go backwards. It wants to herniate. Now, there's no room. When you twist, when you're twisted at the same time, this scalloped area now moves to the side, giving room for the disc to herniate. So what are some things that we normally do that causes disc herniations that I personally see a lot of for young parents out there, myself included? Putting the car seat in your car, taking it out, putting your child into the car seat. You really want to be careful because I actually quite frequently see young parents that herniate a disc. Another thing, playing certain sports like soccer actually can lead to disc herniations. Weightlifters that do squats or deadlifts in a improper posture, and then shoveling snow is really the big one. We see a lot of that because you have a lot of weight to do. It's very repetitive. You're out there working half an hour. And when you're shoveling snow, what I recommend is keeping the weight in front of you and then just moving your feet. The motion that you're going to hurt yourself is when you twist to throw the snow toward the side. What you want to do is just move your feet, keep the snow in front of you, turn your whole body, move your feet, and then dump it. You go slower for sure, but you're preventing an injury. And what I often tell my patients that have a full-time job is, hey, you want to go quicker, but if you hurt yourself, now you find yourself unable to work. And a lot of times, short-term disability may not be an option. Now you're losing even more income. So something to keep in mind. Do not bend and twist at the same time, bend your feet. Sorry, move your feet. So key takeaways for preventative care. So your discs are the primary shock absorbers of the spine. Once they're degenerated, they're kind of degenerated. So you want to take good care of them. Let's say you have degenerated disc already. Well, the next ones to go are the healthy ones. So even for our patients that have degenerated disc, you still want to do these things to take care of your body. A well-maintained disc leads to less degeneration of other spinal structures. So the box on the left is my patient instructions. That it's a little smart phrase that I give to most patients to take home. And what I tell them is I go through this with them and I explain it, but I give them a reminder to take home. Aerobic exercise, you want to increase blood flow to the disc. More blood, your better cardiovascular system. The disc will age slower simply because it gets more oxygen, it gets more nutrients, right? Weight loss, when your body has to do less work, there's going to be less degeneration. Smoking is terrible for your disc. So chronic smokers always tend to have degenerative disc pain. And actually, when I've done discograms, which is when I'm taking a piece of not discogram, discectomies, when I take a piece of a herniated disc out, we actually see that smokers tend to have a very gray disc. So that those smoke particles that you're inhaling, they actually go into your soft tissue. And once they go into the disc, they do not come out. Physical therapy, the purpose of physical therapy is to learn how to do the exercises, do it at home. It's not a massage. You're not going to get a massage. If you need a massage, go to a masseuse. The physical therapists are there to teach your program to help you help yourself. You want a strong core, strong back muscles leads to less injuries because you're not working against something as hard, right? And it'll lead to better, less force along your spine. Your muscles are taking the force. Bending and twisting, we already talked about it. Can't harp on it enough. Discogenic injury, disc herniations, and then something um, relatively new. And so the U.S. Marine Corps actually changed their fitness testing in January 2023. They used to have everyone do crunches as part of their fitness test. They had to pass a certain amount of time. Now they're avoiding that. They're telling people don't do it, do planks instead. Because what we know is that repetitive flexion leads to earlier disc degeneration. It makes a lot of sense, right? When you're repetitively flexing forward, you're bending your spine forward. So it should all make a lot of sense. Holding heavy objects in front of you and bending, terrible. Prolonged sitting, like we said, the disc pressure increased twofold. I say get a kneeling chair, it promotes your normal lumbar lordosis. And then let's say you're traveling, you're going on a long plane trip where you're going to be sitting for a long time, get a small pillow or a Mackenzie log roll, put it in the small of your low back to maintain that normal curvature, okay? So after talking about preventative care, once patients get back pain, chronic back pain, how do we approach the problem? And that's kind of where I come in terms of interventional management. The first step, I will always teach patients how to take care of themselves without doing procedures, without needing medications. But if need be, they'll, having significant issues that impact their quality of life, their function, things that they love doing. That's why we're here. So our approach is pretty much how you would think of a doctor would approach medicine. But it's actually easier said than done because the pressures that the current healthcare system is putting on physicians is quite demanding. You don't have a lot of time. Do you want to spend more time with your patients, be nice, answer their questions, or do you want to, write your notes so hospital doesn't get on you and bill it all? So we combine the patient story, location, 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 strong predictor of where the patient's source of pain is, what makes it better or worse. Then you have your imaging. MRI is the gold standard. You can see the disc, you can see the soft tissue, you can see pinched nerves, you can see the arthritis, you can see fluid within the joints in the arthritic joints. That leads to, that joint is having more motion. And then, of course, your examination. The examination, there's a lot, it's a little less specific. It helps us, but it's definitely not the end all. So here's an example. Let's say I'm seeing a patient that's, age 35. Most of their pain is smack dab in the middle. We'll go over that in a second. They're a smoker. When I look at their MRI, it looks like the picture on the left. The red arrow that I drew is pointing to that small little white dot. That little white dot is an annular tear. Remember how I told you guys a little tear in that jelly-filled, in the dough of that jelly-filled donut? No. We're just looking at a normal donut from the side, normal donut from the side, and that little white dot is the annular tear. And more importantly, it's only one disc that's degenerated. Don't really have to go to years of medical school to see that, right? And then you do a special exam, sustained hip flexion, which predicts disc pain. All those three things combined gives you 94% probability of discogenic pain. That's a really strong number. And I wish all patients would present like this, but that's a textbook. That's just an example of how we use all modalities to come to a diagnosis. And the more complex that patients are, the more chronic their pain is, the more likely you're going to run into multiple things causing pain. And it's really important to stick to the basics and to listen to the patient on what makes things better, not just focusing on the MRI. So location, location, location. We have done studies predicting where every single facet joint in the lumbar spine causes pain to. Healthy volunteers simulated pain in the joint, and then we mapped it out in people. Don't know who would volunteer for it, but people did. That is the axial corridor. So that little green box is the axial line. When we say axial low back pain, that's what we mean. Not too far off to the left and right, generally in this little box. And then your midline component, that's indicated by that blue line. So when you see your doctor's notes on my chart and they said midline low back pain, that's what they're talking about. They mean smack dab in the middle. That's where the pain is the very worst. When we see something like that, it pretty much suggests strong suggestion of disc pain and vertebrogenetic pain. When the pain is more off to one side or the other along the green zone, we're thinking more facet joint pain, especially if patients are on the older side. Now, something that a lot of people don't talk about enough is far lateral. So that purple line all the way out here, yeah, that's part of your low back, but we categorize that as something different. We call that the far lateral, not the paramidline component. When pain is that far, it typically suggests not just the joints or not just the disc. It may be coming from a nerve. And that's going to be really important as we go forward. So this picture will come back. We'll talk about things as each of these items. So your treatment approach. Interventional spine. So what I do involves fluoroscopy. What does that mean? I use X-ray, an X-ray machine, so I can see your spine the entire time that I'm doing the procedure. This picture that I'm circling, that little black line here is the needle. So I can see the spinal bones when I'm doing the procedure. That's how I'm able to do the procedure safely. I cannot see the nerves. I cannot see the discs, but I know what they look like because I've seen your MRI and the anatomy follows certain rules. For example, this little red circle that I'm out, that's the pedicle. I know that if I don't go past the tip, the 6 o'clock position of that circle, I'm not going to hit the nerve. So when we do these procedures, when I tell you, hey, I have not hit the nerve, don't worry, or I'm trying to calm you down, there's reasons for that. It's because I'm looking at your x-ray as I'm doing the procedure. I'm going to skip some of this because we're going to go forward with it later. So really important thing is just a very meticulous diagnosis and workup, right? We want to be sure we're treating the right thing. We don't want to say it's coming from your disc, do an epidural, you don't improve, and then call it a day. We want to see, okay, what is it really coming from? We want to be persistent because your back pain bothers you enough to come see me, obviously impairing your quality of life. We need to take it seriously. If patients are really not improving with your typical care, sometimes we'll do diagnostic blocks. What does that mean? Diagnostic means test. It means we put a little bit of numbing medicine, some lidocaine anesthetic, similar to your dental procedures, along one structure. And then we ask, how much better do you feel? That's a really time-tested way of testing where pain might be coming from when patients are more complex. So these are just examples of how we do procedures. So the picture on the right is from one of my time ago. The red arrows there is pointing to that black line. The black line is contrast. So before I put in the medicine, I put in a little bit of contrast, indicating that when I do put in the steroid medicine, it's going to follow that exact path. So I know exactly where the medicine will go. If the contrast pattern, as we call it, is not optimal, we adjust the needle. So we're trying to deliver the medication to the exact spot that we. So back pain generators we talked about before, your disc, your joints, spinous processes, muscle, vertebrae, end plates. Common treatments and conditions, right? Radicular, what does that mean? Pinched nerve going down the thigh and leg, or pinched nerve in the neck going down the arm. Typically treated with epidural injections. There's different types. Remove the disc if it's pressing on the nerve with either percutaneous through the skin procedures that are ambulatory, or honestly, neurosurgeons do a much better job for large disc herniations, a microdiscectomy. Spinal cord stimulator is a device we'll talk about later. A lot of you may have heard about it. Good option for people that have primarily when we say primarily, what we mean is majority of the pain, the limiting pain is down to the extremity, that axial back. And then for the axial back, you treat this with epidural injections, facet joints with radiofrequency ablation, SI joints with SI joint injections and ablations, spinous ligaments, Bastrop syndrome, kissing spine disease with simple steroid injections. You can treat the tailbone with ganglion PAR injections and the spine mimickers with the appropriate joint injections. So let's talk about treating the axial low back, that green corridor here, which is where the majority of people have issues. The first thing is facet joints. So when people say you have arthritis in the spine, if they are a specialist, this is what they're talking about. If they're not a specialist, they may be talking about degenerated disc or something else. But if you see someone like me and they tell you you have arthritis in the spine, arthritis is, a bone issue. So the facet joints is what they're talking about. So it's a posterior column disease. If you guys remember the model, we talked about the anterior and the posterior. Worse with extension, meaning backwards. When you sit for a long time, the joints get stiff. And then let's say you're eating dinner for half an hour, 45 minutes with your family, and you're sitting comfortable, and you first stand up. You go to move the joint. That transitional movement tends to bother facet joint pain. Typically, it's mainly in the axial areas. It can go down the buttock a little bit, maybe into the thigh, but the worst of it should be in that box, that axial corridor. It's been studied. Like I said, Dr. Dreyfus studied this many decades ago. So we have a lot of good literature surrounding facet joints, predicting which joint it's coming from. It is, I always say, if I can have one issue in the spine, back pain, let it be coming from the facet joints because treatment for it is widely successful. After a series of 2 diagnostic tests, we numb a joint and then we ask you if the pain is better. After that, if both tests are positive, meaning you felt better for a short period, typically a few hours from the numbing medicine, and then we do the radio frequency ablation where we use heat to burn those little sensation nerves to that arthritic joint, the success rate is 95%. Now, some people may say, well, Dr. Lam, why do you have to test it twice, right? That's an extra injection. Well, that's a good question. We used to, not me, wasn't back then, but people used to burn the sensation nerves to the arthritic joint after one test. Only about 60% of those patients improved because there's a very big placebo effect, right? You want it to be a positive test. I want it to be a positive test. When they increased that test to 2, the relief went up to 95%. They went one step further. They tested it 3 times and then did the ablation, 99%. But the juice isn't worth the squeeze. You don't need to test a 3rd time for that extra 4% of confirmation. It's a very safe procedure. In the 50-something years it's been done, not a single person has died, become paralyzed, anything like that, because we're not going into the spine. We're just touching down on the outside of the joint. The diagrams here is just an anatomy picture. So there are these little sensation nerves called the medial branches that comes off the main nerve root. The red line that I'm pointing to is the area where we burn. And essentially you're using heat to denature that nerve. So once you denature the protein, that myelin sheath along the nerve, then it starts to slowly die off. Patients typically start to notice an improvement after the ablation at the 2-week mark. Can take up to 6 full weeks to see the full effect. The pictures on the right is an example from one of my patients. So when we do the test, as indicated by the picture on the left, what we're doing is we're following the anatomy, where that nerve should be, putting a little blob of numbing medicine there, and then asking you how you do. Picture on the right is the actual ablation. You can see that the probe is quite a bit thicker than a thin needle. So I usually warn patients, hey, you might have a little bit more soft tissue discomfort. The probe is a little bit thicker. It's about the size of the lead part of the ink part of a ballpoint pen. And then it's connected to a wire. It's connected to a fancy machine. And it uses radio frequency waves to heat it up, how we quote unquote burn the nerves, as it's commonly known. This is just describing how the procedure goes, but we usually tell patients exactly how it goes, so there's no surprises. Some um, some patients might think, okay, well, I had RFAs in the past and they weren't helpful. What we find is that the way we do these procedures has changed because our machines have gotten a lot fancier. So this whole process, burning the sensation nerves, not new at all. We've decades. Why is it being more effective now? Good question. So on the picture on the left is your standard radio frequency probe. You can see that it emits heat in a kind of, very thin football type shape. The cooled radio frequency, we're running water along the probe, so it doesn't heat the surrounding soft tissue as much, but we're able to create a hotter and larger lesion area, hotter area where we do want to burn in a sphere-like pattern. What we find is that because the shape of the burn looks like this, we're able to do the procedure safer. We don't have to be as close to the nerve roots because we don't have to place the probe parallel to the medial branch, that sensation nerve. We can put it right on top of the bone, nowhere close to your nerve. So what we see is that incidences of, erroneously, injuring a nerve root that might cause pain down the thigh and leg has really drastically decreased with this technology. Moving on to discogenic pain. Now we're moving on to the anterior column. Okay, so discogenic pain is very, very common. And fun fact, back in the day, we didn't understand it was an inflammation problem. We actually thought it was an infection problem, and patients would be prescribed antibiotics, believe it or not. Back pain. It would help some people, mainly because most episodes of disc pain kind of resolve by themselves, not because of the antibiotics. It's not an infection type thing. There's different ways that you can treat the disc. So here's the cartoon picture on the left. So let's say this square is your vertebrae. Where's your vertebrae? In between is that jelly-filled donut that would side. Depending on how and where you want to put the medicine, you can either approach the epidural injection from below the nerve or above the nerve. Discs are graded by the modified Dallas criteria, so we can have this grading system of how injured the disc is when we look at it. And what we see is that grade 0 is normal. Grade 1, you're starting to see some effect of the jelly material, the nucleus pulposus, into the annular fibers, into the dough of the donut. And then all the way up to grade 5, where you have an extrusion. Now you have the jelly squeezing out of it. So epidural injections, honestly, does not help everyone. This pain is very, very hard to treat. So it is known in the medical community that if you respond, that is fantastic. We are so happy for you. About 2/3 of patients anecdotally will respond, especially if they have an acute episode where we're calming down the inflammation quickly. Now, for patients with chronic discogenic pain, chronic disc inflammation, that's harder to treat. Maybe because it's not only coming from the disc, which an epidural injection may not help everything. Something that we do is called a provocative lumbar discography. I don't enjoy doing this procedure because the purpose of it is to induce pain on the patient to see where their painful disc is coming from. By the time you see us for chronic disc pain, more than one disc is degenerating. Now, the likelihood of all of them being an issue is highly, highly unlikely. So when you see us and then we say, okay, the epidurals aren't helping, or they help for a short period of time, but they're no longer lasting, we recommend seeing a neurosurgeon or orthopedic surgery to have a talk about it, whether a disc replacement or a fusion might be the right thing for you. They might say, well, we really want to be sure which disc is the issue before we do the surgery, right? Unlike us, we can do injections and you can come back for injections. They're not that bad. You like seeing us, we like seeing you back. But surgeons, they don't want to well, more than once if possible. They really want to do the right thing by you. So sometimes they'll order this procedure to make sure that they're fusing the right segment, because fusions can lead to earlier degeneration of your disc in other areas as you age. When you're taking away the shock absorption of the disc by fusing those two bones together, well, the disc above and the disc below, or the joint above and the joint below, will get more of the force. When people get annular tears, part of the reason why it hurts is because when you were in utero before you were born, your discs were actually formed before your immune system. So when you have a little microscopic tear, little specks of material leak out of the disc, now your body senses it as foreign material. They'll send white blood cells after it, causing a cascade of inflammation, which then your body processes as pain. So this is how you do the procedure. This picture right here that I'm circling, these thin lines are the needles. We're putting it inside the disc and we're injecting a small amount of contrast. You see the top two discs here, they look relatively normal. The picture on the bottom, the green line here is pointing to maybe an annular tear. And then the picture on the bottom here, that disc is really degenerated. That might be like a grade 4 on the Dallas criteria. So all these things are quite helpful for the surgeon. We don't stop there. After this, which is what we see on X-ray, we typically send patients for a CT scan because we want to be able to see how that contrast moves, and that CT scan will show us a an X-ray picture that shows something similar to the cartoon picture with the red blob.
Dr. Lamb, are all of 3 of those pictures the same person?
Yes,
Like
yes.
these? Okay, great.
Yeah. I couldn't I came from a new practice. I couldn't find, the pictures from my patients. This is just from Google, but it looks
Okay.
very, very similar.
Okay, great. Thank you.
Yeah. Oh, yeah, this is looking at the patient from the front or the back. This is looking at the patient from the side. That's the difference. So something new. In the past, all we had was treatment for the disc, epidural injections, maybe a fusion, maybe surgery, treatment for the facet joints, burning the sensation nerves to the facet joint. And if you don't respond, well, we're really sorry. Medicine has been maxed out. We don't have any new technology to offer you. And that's part of what led to the opioid crisis, right, in the 90s, where pain became the sixth vital sign. And, due to big pharma and, bad practices, we now have a crisis on our hands. This is something new that we're going to talk about today, vertebrogenic pain. So vertebrogenic pain is something that you could think of as the next evolution of discogenic pain. Once your disc become inflamed over a period of time, it starts to affect the bone. What we see is that leads to chronic inflammation at the surface of the bone where the disc touches that can attract fatty deposits into the bone itself. And it changes the end plate. It becomes more porous, and um, inflammatory markers can actually go through it. This ICD-10 code was a big change. This Medicare recognizes this. This is a Medicare approved procedure. It's approved by more and more private insurances now. This procedure isn't talked about enough, but my estimation in that 5 years, a lot of people are going to be offering this. That's why we're trying to bring it to the Inova system sooner. The MRI picture here is a good marker for discogenic pain. So you guys still see my mouse here? Perfect. So this disc is dark, it's dry, but you don't see the end plates, which is where I'm pointing to, the edges of the bone where the disc touches, really be affected. This disc, however, you see that white area, that's the fatty infiltrate I was talking about. So you actually see evidence on MRI of your bone changing because the disc is so degenerated, so flat, that the bones themselves might be touching, irritating, and causing degeneration of the bone. and also the inflammation causing degeneration of bone. The picture on the right is the same patient. It is what the patient's spine looks like after this procedure, after Intercept. So what does this procedure do? The cartoon picture on the right here is a good illustration. The end plates are where I'm, going through with my mouse here. The end plates are innervated. Do you guys remember how we talked about the concept of a pain generator? Any structure in the body that has sensation nerves to it brings the sensation back to your brain. That's how you sense it. Well, there are a lot of sensation fibers that goes to that place. And then they funnel and they connect to a main sensation nerve highway here. That's called the basovertebral nerve. And by burning that pain nerve highway, patients are getting really, really good relief. They've studied this technology for over 10 years. Out of everything that we've ever done, this procedure has the best outcome. These are level 1 randomized controlled trials. You don't get more high-level evidence in medicine than these trials. So like I said, this is a really big way in how we think about back, because we've never had this technology. We can help. That nerve I was telling you guys about, the basovertebral nerve, we didn't know it existed until 2003. That's very recent in medicine. We've been studying anatomy for a very long time. So for it to have just been recognized and found out in the last 2 decades is huge. What we see is that the end plates, how I think about it is your vertebral body is like a can of soup. Top lid of the can and the bottom of the can, that's what we're talking about. Those are the end plates. They are actually more innervated than the discs. What we're seeing is that under histology, when your disc is altered in structure, it's all degenerated, there's these broken in the middle, it's extruding from the sides. What you're seeing is more and more blood vessels and instability along the soup and lids, along the end plates. It leads to increased porousness of those end plates. It leads to increased inflammation. Some patients are more prone to this than others due to the way they treat their body, right? That's why we talked about prevention and also genetics. Unfortunately, some patients are more prone to disc injury than others because the disc itself isn't able to hold as much water or it breaks down easier. Who are the patients that have these issues? And how do we know they have these issues and it's not just coming from arthritis, right? The range of patients that presents with these bone pain, these vertebrogenic pain, is quite wide. You can see 30-year-old patients with this issue. You can see 80-year-old patients with this issue. How do we tease out whether this is coming from facet arthritis, arthritic joints, or whether it's coming from the bone? Go back to the idea of an anterior column. These are patients that have limitations with sitting a lot, bending down, picking something up, tying their shoes. Maybe they go down and they garden. Tired now, they're going to garden. They have to spend a lot of time in the kneel position. They're working on their plants. Those patients present with this quite a bit. And we think of this as an anterior column. So like I said, this nerve was only discovered in 2003. This procedure that I'm talking about, the basovertebral nerve radiofrequency ablation, is actually quite easy. So for those of us familiar with kyphoplasty, going into the bone to fill it with bone cement or compression fractures, and also the radiofrequency ablation we talked about, burning a sensation nerve, this is kind of like those two technologies had a baby. So what you do is you go through the pedicle, make a canal, take out the probe, insert the probe that has the heating element, and then you ablate the nerve. For really skilled people, this can be done within half an hour, typically done at outpatient centers. This is not considered a surgery. People go home the same day. One of the main things to realize is that unlike radio frequency ablation for the facet joints, for the arthritic joints in the spine, those nerves grow back. So the medial branches, they are myelinated. They're a particular type of nerve. They grow back, they reattach. And then that's when you go see the doctor again and you say, okay, the RFA, the ablation lasted a year. I'm back. Let's repeat it. That happens very often. This procedure, the basovertebral nerve ablation, is a game changer because that nerve does not grow back. This is a one and done deal. The basovertebral nerve is not myelinated. So that's why. That's the big difference. And that's something that even a lot of doctors are still grasping their head around. So contrary to historically how we've been treating patients and managing their back pain for several decades. So indications. This is more for the providers in the room. Typically, you want patients that have at least 6 months back, have tried more conservative measures. We don't want to jump to something fancy and new just because it's available. We want to do the right thing. We want to find patients with imaging findings that support it is a vertebrogenic bone issue. A hamburger sign. So you look here, it kind of looks like a hamburger. That bony part, the fatty part is the bun. The dark degenerate disc is the meat patty. That's a classic thing. If you see that, yes, that's like a textbook picture. But for the vast majority of patients, actually, and also based on the updated studies, what we're seeing is patients don't have to have a classic hamburger. And by only looking for that to see if patients would benefit, you're selling the patient short. The picture on the bottom here, that may look like a sandwich, right? Not a classic hamburger. Even when you see findings like that, what we're seeing is patients respond very well to this Intercept procedure. And then you have your caveats. So I had a patient just, several years ago that saw me as a second opinion back in my last practice. She was, a typical, very healthy athlete, took great care of herself, 50-year-old woman with pain in the back. She has one degenerated disc. She has one area where there was a classic hamburger sign. We did the epidurals and she actually responded really well. The reason why she saw me, well, she is really smart, looked up medical journals, looked at this Intercept procedure, referred herself to UVA, and talked about the Intercept procedures to see if it's right for her with the doctor. They were gonna do it, but at that time her insurance didn't cover it. So then she sought me as a second opinion. I said, okay, well, it's definitely worth a try doing the disc. We did it. I had treated her for 2 years and she was doing great. At the last remaining 6 months of the 2 years, the injections started to become less effective. They weren't helping her for as long of a period. So we said, okay, this may have changed. Your spine is a continuum. This may have changed from discogenic pain into more fibrogenic pain. That's how these things evolve. And that's how I went about it, is that it's not just one thing or the other. They exist together. Ultimately, she did end up getting the procedure at UVA, and unfortunately, she actually did not respond. She's actually one of the very rare people that did it, because it turned out her pain wasn't coming from sensation nerve in the bone. It was really coming from the disc itself, these inflammatory markers at the disc level. That's not to say she may not improve later on down the road, because the Intercept procedure does take several months sometimes, a hard sell for some people, but that's what we see sometimes. So outcomes. Long-term outcomes are fantastic. We've been studying these procedures in randomized controlled trials, the gold standard in medicine, the most objective, unbiased studies, and the outcomes are just fantastic over the course of 5 years, over the course of 10 years in some studies. These scales are pain levels, different pain levels. So you have your VAS and ODI. ODI is your disability index, the patient's improvement in function, a lower score indicating better function. So typically patients would be around 45, 48. They would come down drastically. That's a over 20 something percent difference in the ODI score. Now, I just want to point out, if you have surgery for your back, a significant score, a significant reduction is considered 15%. So if you have a 50%, 15% reduction in your ODI score, that is considered a very successful surgery. Just putting things into perspective. So the key points from those things, we really have to find the right cause. We really have to do good detective work, practice responsible medicine, and not just say, we see some arthritis on your x-rays, on your MRI, it's coming from your arthritis, we're going to do the ablations, you're going to feel better. That's not the way to approach things. We can say it's likely coming from it, but when patients don't respond, we have to think of an alternative pain generator. Newer options are available. Really, the main issue right now is access to care and also implementation. A lot of providers, a lot of physicians are not aware of the new technology, or maybe they don't feel comfortable training in something new until it becomes more widely adopted. So these are kind of the main barriers we're seeing to intercept right now. How are you doing on time? That's been an hour. So that's only slide 38 of like 60 something, because I always come with extra slides. I wanted to take a break and see if there's any questions before I move on to the remaining 30 slides.
So we're at about 7:35. Told people we would end at 8, and there's about 13 questions in the Q&A. So maybe I can just run through those. Let's actually take Kimberly, who has raised her hand.
Yes, I'm going to be babysitting my grandbaby, and I have back problems. I was wondering if you have any suggestions on how to lift a baby out of a crib and how to lift a baby out of a car seat or stroller.
Yeah. So, can you see me on the webcam?
You're very small.
Okay. Let's say, let me see here. So I'm going to stop the screen share for a second. Okay.
Okay.
Can you see me bigger now?
Yes.
Okay. So I'm going to step farther from the camera. So this is sometimes what I do for patients, is I show them, because being is a lot better than being given words. So let's say I have, my 3-year-old in front of me. Let's pretend this chair is it. What do most people do? They bend forward like this. They lock their knees. They load their discs. They bend backwards, injuring their disc. And let's say they're taking them out of the crib. Crib's high. I know. I got 2 of them. They twist. So now you just bend and twist at the same time. That's not the right way to do it. What you want to do? First of all, buy a crib with a lower fence or something that works for you, because what you're supposed to do is keep your back straight, bend at the knees, do a really good squat. You can work on this at the gym. Keep your back straight, pick up the chair or your child, go straight back up, exactly like how you would do a squat. Now, move your feet instead of bending. And that's the most important thing I'll teach you today.
I mean, I don't have a lot of strength in my knees, so lifting, I don't know if I could do that. But
let me tell you, it is going to be a lot easier to work on the strength in your knees than the strength in your back.
Okay.
So if you have knee pain, I encourage you to see somebody, maybe go to physical therapy. Something else that you can do that's a good isometric way to work on knee strength is doing wall sits. So that's a good way to strengthen your quadriceps without having to flex and extend and bend your knee. But I really don't want to give too much medical advice. Really, I want to stick to any questions on the presentation and things that we discussed today. But I hope that was helpful. Oh, no problem.
Well,
I hope that
that's
was
a big reason I wanted to do this, because I have to find out how to do it. All right. Thank you.
Yeah, you're welcome.
Great. Inside the chat, we had a couple of people ask about the kneeling chair, and somebody had heard that it was not great to sit in those for a long time, and people want to know how long is the maximum time they should sit.
So I don't know who said that, but if if you think it's not good to sit in those for a long time, you're probably doing a bad job sitting in that chair. Buddhist monks who pray for 12 hours a day sit in those chairs. So if you do it the right way, use good posture, it is the best for you. Um, what we do find and why patients may not find it helps is because you're not used to it. You don't have the existing back muscles and core strength in order to sit in that chair properly. And I think that's a good segue into why interventional treatments alone is not going to help. Going to your physical therapist, learning how to use your body correctly, strengthening your existing musculature is going to be key in how we tackle your problems. Anywhere from sitting in a kneeling chair to preventing, discogenic injuries.
Okay, great. What causes the stiffness or creakiness or slight pain first after you wake up? And that pain that usually resolves. What causes that?
Yeah, so that's a pretty classic story for facet arthritis. That's probably the small little arthritic knuckles in your spine, the facet joint. So you're sleeping all night, they get stiff, and then that's a kind of classic story. The first 30 minutes or so, you find it hard to get up, you're bending and it hurts. And then it starts to improve as you walk a little bit, improves once you take a hot shower. Those are kind of classic things we hear.
Okay, great. Are back issues genetic? If a parent has gone through back issues, will I?
So unfortunately, there's a strong indication that it is. So it depends on what. Um, if you have a strong family history, like multiple uncles and aunts, grandmother, grandfather that have degenerative disc disease, chances are you are susceptible to it. Your discs themselves are just not um, very good at holding on to water. The little molecules inside the disc that collect the water, like tree branches that stick onto the water, they just break up easier, they degenerate faster. And that's what we see.
Okay, great. We had a couple questions about sciatica and whether or not that was a result of a spinal issue. I could answer personally, yes, that is that
Yeah,
is.
so that was the remaining 30 something of my slides. So um, sciatica, this is my little plug. Sciatica just means leg pain. We don't know from what. Is it coming from a nerve in your thigh and leg? In which case, I consider that true sciatica because it's coming from your sciatic nerve. Or is it sciatica type pinched nerve in the spine shooting down the thigh and leg? We have studies. Again, I don't know who would volunteer for this, but people did. We stimulated nerve roots in the spine and we mapped out where pain goes to. And we've done these studies a long time ago with ample evidence that helps us predict which nerve is the patient's pain generator if they, in fact, happen to have multiple nerves that are pinched at the same time, because not all of them are inflamed at the same time, I guarantee you.
Okay, great. Let's do a couple of patient scenarios. So one person has asked, I only have pain when I stand or walk for more than 10 minutes, no pain while sitting. MRI showed mild to moderate stenosis and disc degeneration. Physical therapy and injections haven't worked. He exercises they exercise every day. They're 73 years old. It's getting worse. Is there hope?
Yeah, so there is. In about talking about radicular pain. So radicular pain is what we call sciatica.
Okay.
Radicular meaning because the radicular nerve roots, those are the name for the nerve roots. They're the ones that ultimately form a plexus, form a network, and then
Okay.
form the major nerves down your thigh and leg. That's why when you pinch a nerve in the spine, you have pain down the thigh and leg. And there's actually really good treatments for it. If we are not able to help you with minimally invasive procedures, our neurosurgery group here is excellent. They will be able to help you. The secret is most surgeons in the country do not like operating for just back pain. The success rate is not super high. They don't want to do surgeries that they're not confident will help you. On the other hand, pain down the thigh and leg, super high success rate, over 90%. They love doing it because they want to see you smile. They want to hear those stories that, hey, I'm able to stand and walk and go hiking. They want to hear those stories. So I would say, yes, there's absolutely hope. And if you don't see one of us, please see our neurosurgery group. I used to take care of a neurosurgeon. He was a friend. And when he needed surgery, he came to Inova to get it. And that's saying something.
That's great. Yeah. Let's talk a little bit about yoga. Is yoga considered one of the best preventative practices? And are there any yoga positions you think may be harmful? I actually had a kind of a similar thought when you said don't bend and twist at the same
Yeah,
time.
yeah. So yeah, so I'm hesitant to say don't do it because so many people find relief with it. It keeps them limber, um, your range of motion. I would say don't do sudden movements. So, like there's like hot yoga, like I think like Bikram yoga, where you're doing these dynamic motions. I think those are the ones where you're easily herniating disc and things like that. But if you practice more gentle types where you're not doing these explosive movements, I don't really see an issue with it. Um,
Okay, great. What do you think of chiropractors? You get a couple passes if you want to if not you want to not to answer that one.
Oh, I actually I haven't developed my network here in Inova yet because I just joined the area. But back in my last practice in Winchester, I actually had several chiropractors I would refer patients to. They
Okay.
do really, really good work. Now, there are certain things that they are very helpful with and certain things that are less helpful with. So if you have a herniated disc and a pinched nerve, what are they going to do manipulation wise to get that disc back to where it belongs? That's kind of hard. But if you have a stiff joint, that joint capsule is just the wrong way. It's just kinked. Well, they do excellent work. A lot of times I send patients there and they improve. We end up not needing to do an injection.
Right. Didn't expect that answer. Let's see. We covered genetics. This person has back spasms once or twice a year. Feels like a cable coming off of a pulley. They resolve within a week or two with no intervention. It's always mysterious, never diagnosed, even after an MRI. Any
Got it.
ideas?
Yeah, I'm gonna take a pass on that one because that's so non-specific. For me to give a diagnosis based on that information is that would be an insult to your intelligence, honestly, because there's nothing I can say that actually would be, intelligent. So
Fair
sorry
enough.
about that, but I welcome you to come see us, and I can actually do a consultation and see.
Okay, great. And that's totally fair. Thank you for that answer. Okay, I heard corticosteroid injections damage the bones. How true is that?
So when people say that, they're thinking about joint injections into the knees and hips. Steroid injections. So steroid actually, so it's known, they've done studies like decades ago that it impairs the activity of the chondrocytes. So those are special cells on the lining of your joint that creates pore lining, creates lubricant that keeps your joint healthy. And if you get the steroid injections too often, it can lead to earlier joint deterioration. The same thing is not true for spinal epidural steroid injections because we're not putting the medicine into a joint. We're putting it into the epidural space. There are no chondrocytes, so that's really not an issue in the spine.
Great. All right. Can you talk a little bit about spinal cord stimulation? And can that help facet joint pain or arthritis causing sciatica?
Yeah, so spinal cord stimulation, it's predominantly for pinched nerve pain, for lumbar radiculopathy. So the good candidates for it is patients that have had surgery and they're having new pain down the thigh and leg or still having some persistent pain that's bothering them. They feel so much better. They sent the surgeon a Christmas card, but a few years later, your spine continues to degenerate. You're having pain, and they're not really candidates for repeat surgery. Those are great patients to consider a spinal cord stimulator. Other patients, they have comorbidities, heart disease, where the surgeon might say, hey, your health condition really is not safe to undergo major surgery. You might want to consider a spinal cord stimulator to other patients, but it does not help fix that joint pain. It helps some patients for back pain, but primarily it is for thigh and leg extremity pain from the pinched nerve.
Okay, great. Aren't the ablated sensation nerves necessary?
Not unless you're a high level Olympic athlete. So the sensation nerve, the So specifically, what I'm talking about is the medial branches in my presentation in the lumbar spine. They go to a very small patch of skin. So you might have some paresthesia, some altered sensation in the skin that goes away after the burn, after the RFA. And it also goes to a very small muscle called the matifidi. The matifidi is a muscle that helps in balance, coordination, but not in terms of strength. It is a very small muscle. So if you're a high-level Olympic athlete and you need every position since you know need to break world records, yeah, it's gonna be might impact your Olympic level performance. But for the vast majority of people with arthritis that get this kind of procedure, I tell people don't worry about it. It does not make a difference.
Great news. So HRF is more for facet joints and intercept is more for disc. Is that correct?
Sorry, can you repeat that one more time?
Sure. HRF is more for facet joints and intercept is more for disc. Is that correct?
Oh, the RFA, you mean? Yeah. So the radio frequency ablation is for joints. The Intracept is for technically bone, for bone pain. So I know I said the vertebrogenic pain, the end plates, the cans of that, you know, the lids of the can of soup. Technically, that's bone. So I think of it as bone pain, but people think of it as a progression of discogenic.
Okay, great. Um, would you do intercept before high frequency stimulator? I'm currently doing an HFQ stimulator trial, but it's going to take 2 months to find a doctor to do the permanent one. This patient's fused from L2 to S1 and bedridden.
So I hate to give medical advice like this through, you know, I have very limited information, but I would say here's the general thing for the spinal cord stimulators. You have to do a trial before you get the permanent implant. You have to test drive the car before you get and buy the car. If you don't like the way the car drives, don't buy the car. That's as simple as that. You're not waiting around because the thing is, the spinal cord stimulator is really treating a different thing. It's treating sciatica type pain. The other procedures are treating more joint pain or bone pain. So they don't really, you shouldn't think of it as one thing or the other. You should think of it as, hey, I scraped my knee. I can just put antibiotic cream on it, or I can put just a band-aid on it, or I can put antibiotic cream on the band-aid and then slap that back.
Okay, great. Let's see. I think I have pain in multiple areas, facets and SI joints, also disc degeneration. How can I and my doctor find the place where the pain is coming from?
Yeah, so it's going to be like those three circles I discussed. It's going to be using good investigator skills, seeing what is the primary source. So it may be that you have multiple things causing pain. It's allowed. The key is asking which one of those pain locations, because they're coming from different things, is limiting you the most, and then tackling that first. If it becomes refractory to treatment, like let's say you're really sure your pain's coming from the SI joint and you get an SI joint injection and it didn't help. Well, it's time to think, is your pain really coming from the SI joint? Right? So maintaining that open differential, keeping your mind open on really what is the cause. Am I wrong in my initial diagnosis? And you know, responsible doctors aren't ashamed to be wrong because they're using everything they know, your presentation, your imaging, to come to the first diagnosis. But medicine is complicated, very complicated. And especially spine care, like I said, there's so many things in such a small area. Your initial impression can be wrong. What's important is to not give up and find really what's the source of your pain.
Great. Okay. What is normally the source of a burning or stretching pain down the backs of both thighs?
If it's
Uh,
coming from the spine, like let's say you
yeah.
have an MRI, you got a pinched nerve, my guess would be the S1 nerve root. If you're on the younger side, L5-S1 disc herniation. If you're on the more elderly side, likely some spinal stenosis pinching that nerve. The caveat is a lot of things can cause pain down the back of the thighs that are not coming from these spinal nerves. So having an MRI is helpful. If you have a pinched nerve, fine, that we see most likely. If not, it may be the sciatic nerve itself in the thigh. It may be piriformis syndrome, a pinched nerve within a small muscle within the buttock. And going to see your healthcare provider, they do exams, they ask you stories, doing that investigative work to come to that conclusion.
Okay, great. So I have 3 more here that I'll ask, and then I see that Leonard has raised his hand. We'll go to him last. Can foot drop issues be cured?
It depends. So I see some patients that with acute foot drop, the nerve is just not foot drop is usually caused by the L5 nerve. The L5 nerve is responsible for the ankle going up. That's why when you walk, the foot is slapping the floor because you don't have the strength to bring it up. So if that L5 nerve is just inflamed and it's not functioning well, causing the foot drop because it's inflamed, after we do an injection, we see that the foot drop resolves. If it is a more chronic issue, if it is because that nerve is starting to become affected and injured, then it may become permanent. That's why it's really important when you have neurologic deficits, meaning loss of strength and having numbness, to go see your doctor. Do not wait, because we don't want these things to become permanent.
Do Entrecept spinal injections have a role in helping radicular pain?
They do not. It is solely for back pain. Good question.
All right. So I think that we've hit the end of the program. Like I said, if we didn't get to your question, I apologize, but I will be following up individually as best I can. Really, really informative. Thank you so much, Dr. Lamb. Thank you, Shamila, for joining in and helping us get all these questions answered. It was a really good group. Great talk. I'm so sorry we didn't make it to your whole presentation, but maybe we'll just have to do another one sometime.
Happy to go through those in more detail. And really thank you everyone for taking your time this evening to be here. And thank you for the really excellent questions. And I hope it helps people figure out, hey, spine care is complicated, but that's okay. We work together on this.
Sounds great. Thank you so much. All right. And everyone have a lovely evening. And with that, we will conclude.